CMO or some lead clinical side, a COO, and then a data person. Data, quality, even just an IT person, whoever knows the system of their EHR the best. Okay, so, when we go through this, I'm not gonna go into all these details, but with the new change, with this new tool, from the PAT 1.0 to 2.0, they really pumped up how they score and what does this look like? Once you get all these scores of 0, 1s, 2, and 3s in here, what does it even mean? So there's in the Excel version, there's actually tabs for the scoring, and there's 3 ways to look at it. So how many of the 15 secondary drivers, so it's the 15 secondary drivers, and the aims is having your strategic vision, having your baseline data, your plan. So that's the 16. Then you can also look at it as counts of how many concepts are completed under each phase, and then just an overall score. So that's something that I think it's important to look at, slice things more than one way, and they've been able to achieve that somewhat in this new, the PAT 2.0. So, just thinking, I've shared already a lot of lessons learned that we've experienced, but I think one of the biggest things is just finding synergy with other programs, strategic goals of the organization. We're not here to have our agenda and make you do everything. We're saying, hey, we're here to help. What do you need? What are you already doing? Where can we really give the support of to something that maybe you've wanted to do but haven't had the capacity to do yet? So, thinking about the Department of Health Services, this started very small, and then once we got more buy-in, it started going up the chain, and really seeing how could we use this in a strategic way to then also help with our DISRIP program. A lot of the PRIME measures that are part of the DISRIP program are we can achieve improvement on the diabetes ones, the BMI and follow-up, the depression screening are all on PRIME. And so, when you're able to focus on a few measures, that the learnings can then be applied in, as far as a data perspective across any measure that you want to improve. And so, as we went through, we realized this isn't a rote exercise. We didn't just come in and read each milestone, tell us what your score is. Once we got into it, we really learned that this is a great way to start engaging our practices, being there, listening to their complaints. There's a lot of stuff going on out there, so we're not there just to push our own agenda. And then when we think about these,
who does the scoring? Do you guys do the scoring, or does the organization score themselves?
The organization scores. We talk about it. So each milestone, we say, what do you think? Where do you fall on this? Oh, we're a 2. The other person next to them says, we're a 1. We're not there yet. And it's a big conversation just to arrive on one number. So, that's where I take lots of notes and, start finding the holes and the gaps and things. And then towards the end, when I go back and I say, where do you need help? I can take some of these examples, because we don't want to ever write down a score greater than 0 without having some examples. So you do this, how do you do it? What is it that you're doing?
Really quickly, you said something really important. I just want to make sure, does everyone know what the PRIME measures are that Whitney was referring to? Who is familiar with the PRIME measures? Oh, of course. Could you take a minute to explain this? I think that alignment's really important in terms of the work you're doing.
Yeah, so I can share my understanding of it. We're working with Dr. Seto. He's on the primary care work group at DHS, and he's responsible for DHS's improvement on, I think there's 50 PRIME measures. So in the years to come, I don't know the timing exactly, if you're able to achieve high performance on these 50 measures, a lot of them around population health, preventive health screenings, and certain chronic disease states, Department of Health Services will get $200 million more in money to them to then help take care of their patients. So this is a huge strategic initiative that we've linked in with, and now our measures are gonna be on their dashboard too, and we are gonna be a little part of it and help them also then achieve their greater goals of all 50 measures improving. Does that explain it well enough? Okay. Awesome. So, you know, as we go through this, you know, we asked, what are your intervention ideas? It could range anything from, we don't know anything about this, we want more learnings on this. Some of our smaller practices are like, we want to have a dinner. Most of our other agencies, you know, our community clinics say we want it all webinar based. So, you know, we're going to be flexible with how they want their education delivered, what it's going to look like. And most everything will always have the webinar-based learnings that we can leverage our LA Care, CEU, and CME departments. But you know, we want to try to do those interventions that will hit the most measures or hit the most aspects of those 16 secondary drivers. And we also need to have enthusiasm for this, or what's the point? So, you know, if they don't really want to do anything with you know, their A1C is greater than 9, at least we can focus on getting people screened for depression. You know, and then over the next 4 years, we can keep working towards our overall goals. But, you know, it doesn't have to be all at once. And so, like I said, we're just really, at this point, finding synergy with each of our network partners, figuring out how this is going to look for them. We're going to start training our practice coaches, where we have our initial kickoff of all of our coaches, you know, focusing on data use and Plan, Do, Study, Act, the PDSA cycles, and how we want to use our monthly data to really start generating change. And so that's going to be part of our learning collaborative. I talked a little bit already about our clinical data repository, which will upload all of our clinical quality measures into that, and we'll be able to roll it up, get different pictures of how that data is cut. We're also working on a project management interface and linking that with our CRM, our consumer client relations management. Yeah, so we have our Salesforce, and since HIT has already been in the practices of many of these people years ago for helping them get their initial EHR set up, we already have some baseline information by linking those things together. You know, which measures did they use for their meaningful use, things like that. And then now we're in this iterative phase of, we've collected all these interventions through our practice assessments, and now where do things align? So with, for example, CCA-LAC, we did 26 assessments. By the end of that, we had over 100 intervention ideas. We've now taken all of that, started condensing it, really figuring out what are these core needs, and we've done that with each of our network partners. We're in the process, but it typically just breaks down into about 9 to 15 interventions. So, you know, we can really achieve some of these changes in practice transformation with just a handful of interventions. We'll implement our interventions all focused on those primary drivers, which will then lead to our practice transformation, moving them through the phases. We'll start performing on our outcome measures, be able to meet that deliverable to CMS, and then reach the TCPI goals. So, you know, really having these practices be ready for the alternative payment models and things to come. Okay, so I'll hand it over.
And I don't think that any other PTN is doing what you're currently doing. Okay? And I'm sure you will learn a great deal after doing this. Another thing that you talk about, all the process metrics and all the outcome metrics. Number one is, my concern is at times we are too focused on the process and just forgetting that's the outcome. And I would hope that you have a starting point with the practice to tell them where they stand on diabetes or depression. And then at some point when they start, they're very excited, enthusiastic going to this, and at probably 3 months, 6 months, you can see whether they move the needle or not to get the enthusiasm going. Because without that, we just talk about process. At some point, people got really tired with all the processing.
And that's something through our clinical data repository, our CDR, will be, right now we're collecting all the baseline data, which is for measurement year 2015, for all of the CQM measures that we have. So we have a baseline, and then we'll be able to show over time, just in a plotting that across time, where they've stood at initial and where they're able to get to. And quite a few of our smaller practices especially, you know, their meaningful use reports, they print them out, it's 0. So, you know, we're starting low on a lot of these just because they're not documenting in the place in the chart that's gonna run where the report's running it from.
Illness and then be cognizant to know who to refer. How are you doing this when you're doing this mass screening with PHQ-9s, and how are you training the clinicians to take that patient with the high score and immediately take an action on that?
Yeah, so that's the wonderful question. And to my surprise, actually a lot more practices actually do the screening, but then it stops. There's no follow-up referral process. And so what and I get back to your question, a lot of our work here tie into some of the incentive programs that we have through our QI department. So to answer that question, we implemented e-management program within LA Care for a certain amount of provider. So for practice like that, we get them onto our e-management platform where we automatically collect the number of screenings that they've done, and then we actually pay them for the screening that they've done. And then we want to push them to the next step, right? And that is to start treating these people for the mild anxiety and mild depression. And when you stuck, we have a specialist on this end that you can talk to, and then to help you guide your treatment. Once you've done that iterations of communicating with the specialist that give you a solution to treat the patient, we pay you for that, right? And we believe that when you do, you know, you do a lot more of this, then immediately you learn the next time the same patient come in with the same condition, then you know what to do. So that's our go-to. And a lot of it is driven by education. And the other platform for our provider who does not have the e-management piece is I'm in negotiation with New Mexico University to bring Project ECHO to LA County, and we're going to make it available for our provider network. So those of you who don't know Project ECHO, Project ECHO is a way of bringing training treatment to the provider rather than doing a lot of referral, and it's become international evidence-based practices in training PCP, dealing with cases that's very difficult cases where in the area there's a shortage of specialists. Even while we're in LA County, we do have a shortage of specialists. For those of you who work for Healthland, you know what they are. So we're getting ready to launch ECHO project. As a whole nation, we are moving towards integration of care, specifically physical health and behavioral health. And as I mentioned earlier, particularly to the Medi-Cal population here in California, at least into 2020, is a carved-out system. So it's very difficult for PCP want to care for the whole person. And even though there is this availability of mental health on the carved-out side and the health plan side, sometimes what we found is that a patient who needed the mental health services being referred by the PCP for the mental health professional to provide the care, but they refused to go. We see that all the time. So PCP ended up having to do the care, and sometimes it is out of their scope of practice. And we want to be able to create a learning process, not only for the PCP to know how to handle, lack of a better word, or coordinate the care for these people, but also build the infrastructure for eventually, if we still stay with the capitation model, is that we would want to capitate the whole person care, all the funding to the PCP to provide all of this, right? There's not enough psychiatrists, we know that. My psychiatrist friend in the room will tell you that. There's not enough psychiatrists, there's not enough therapists, at least in the state of California. In 2012, the California Institute of Behavioral Health Solutions did a survey and worked with the state, and we realized that in the Medi-Cal line of business, which constitute a third of Californians, there are about 4,400 shortage of mental health professionals. So you really need to embark on the help of the PCP. And so the therapists that we have would need to be really concentrating on short-term solution rather than the traditional understanding of lying on the couch doing analysis for years after years after years. We can't afford that. And our psychiatrists really need to be at the top of their training in treating most appropriate and difficult cases, and not the cases where a PCP could do the intervention. And we know that on the PCP side, diabetes and depression are two conditions that they see the most. You have PCP in the room, correct me if I'm wrong. On the mental health side, they see depression, but the diabetes come because people in the mental health side who are on antipsychotic medication are at higher risk for developing diabetes. And we do know that on the mental health side, the psychiatrists have not been doing a very good job in coordinating that care with the PCP in order to monitor the patient. And that's how we marriage these two conditions and creating a flow for them to communicate. Not good enough to change the practice in the physical health side, but you need to change it on the mental health side so that they flow together. If they each build their own flow, and at the end they don't communicate with each other, you still do not have the outcome that we're supposed to have. I hope that makes sense.
Thank you. And then I would just say operationally, other practice transformation networks are focusing on 20 different measures, all different types, letting people pick and choose which measures they want to focus on, which might work for them. But since we wanted to focus just on LA County from our stakeholders when, writing the grant, these were two disease states that were very important to them. And then also, it's a way to sort of keep our scope and our resources and our, who we have, our, our partners, our vendors, like IBHP. So, we want to utilize our resources focusing on these disease states, but a lot of the things as far as practice transformation, we can extrapolate certain processes to then cover other disease states. But I think this is a good way to keep people focused and have everybody be on the same page of achieving outcome goals around a certain disease state versus just blanket quality improvement as if it's another HEDIS program or P4P program.
And to severe mental illness network. If, for those of you who are pharmacists and psychiatrists, you remember the CATIE trial, right? So the CATIE trial found that 80% of the subjects, people with severe persistent mental illness on antipsychotic medication had dyslipidemia. 62% of those subjects has hypertension, 30% of subjects has diabetes, but none were receiving any treatment. That's the scary part. And that's why we know on the average, our patient with SMI, severe mental illness, live 25 years shorter than the average population. And then also study from the RAND in 2003, I'm not going to go to the data piece, is just point out to the importance of the integration of care on the behavioral health and on the physical health side for this set of population. Another Medicaid review from Missouri showing, again, people who belong to this subgroup have a highest cost for us as a system overall. There's a slide that gives you reason. We make this slide available to the folks. Yeah, gives a reason on increased cardiovascular disease mortality in people with major mental disorders. So this is a project that built strongly on the established multi-state consortium developed under the Rutger Award that I participated in Orange County when I was working for Orange County Behavioral Health Department. That part, the first piece of it is identifying how would you help a psychiatrist be aware of what is required of a psychiatrist based on the standard of care. Particularly it's related to prescribing antipsychotic medication for people in the system. And to our amazement, many psychiatrists was not following the standard of care in terms of measuring diabetes, BMI, and weight for individuals that they prescribe antipsychotic medication for. And worse than that, there's no communication between the psychiatrist and the PCP. Now, we can spend half a day in discussing why that is. There's system barrier, there's structure barrier, and there's finance barrier. the whole point of MedNet is, at least as a psychiatrist, what is it that you are responsible for when you prescribe this medication? Whether it be you monitoring yourself or you communicate with the primary care physician to ensure that both of you are monitoring these core elements in the care of your patient. So with the SMI-Net, the next piece is to target individuals with severe mental illness, and we convinced Rutgers University to move their project up to LA County. We got the LA County Department of Mental Health very interested, and because they also, as a system, want to know how well they've been performing as is relating to the care for individuals with SMI, and particularly for those who are on antipsychotic medications. And there are several go. We've gotten community partner and stakeholder, Los Angeles County Department of Health, Los Angeles County Department of Public Health, which has the responsibility for the SUD piece, substance use disorder piece, and then our stakeholder, our regional consumer advocacy committee. And what it is together we want to move our expectations and how we co-manage individual with SMI in Orange County, in LA County. Sorry, I still say Orange County, I still live there. So the logic model of the SMI and SKI process is we establish a baseline quality profiles and the problem analysis, then we move on to identify intervention strategy. And we utilize RCME program to bring evidence-based practices, education, and technical assistance to both the PCP as well as the behavioral health provider. Now you're beginning to see how this tie into LAPTN. And this project started before we got funded for the LAPTN project. Together, the behavioral health provider and the PCP will develop and implement the QI plan and intervention. And then we deploy and incorporate metrics into the ongoing care processes, evaluating the impact. And that's why I said not only the practice of the physical health side and the behavioral health side have to change, but that practice has to somehow match and meet at the middle point in order for them to really achieve this this core measure, right? The improvement in this outcome, right? Because you're not treating two separate patients here. That's the thing that we've seen, that is that one person, depending on which system they go to, they are being treated as a separate individual, and nobody helped put the whole person together. And it's reassuring for me to see my psychiatrist colleague nodding her head. She knows what I'm talking about. Up and down the state, not just LA County, DMH, okay? And then if they fall out of care and they get back in the psych ward, and you know if they have co-occurring diabetes, high blood pressure, all this chronic physical health condition, the first hospital they end up in is the acute hospital that the health plan is responsible for, right? So how do you do this? How do you prevent people from how do you help people, not prevent, how do you help people from getting the optimal care at the right time, at the right place? That's the goal of this project, okay? So clearly, improve management of comorbid conditions, measure, monitor, and feedback quality measure, and then improve the use of evidence-based practices for people with treatment resistant. So that's our first learning collaborative. I know I went really fast through it. And here's the other learning collaborative that we have nationwide. So the first piece, we are participating representing the state of California, and then there's 5 other states participating in this nationwide learning collaborative at Rutgers University. Texas, Ohio, Oregon, Wisconsin, and there's one more that I completely went blank. Those systems, the involvement is at the State Department of Healthcare Services. We here in California, LA Care, work with our Department of Healthcare Services, and we are the representative for the state of California. The second learning collaborative, remember how I said you can come up with all of the workflow you want, you can put clinician here and there if you want, but if the payment system are separate, you still struggle with being able to integrate the care, especially for the individual solo practitioner, right? For the medical director of the health plan. You know that when your solo practitioner make a referral for the patient to see a behavioral health specialist, they kind of disappear in the abyss. Especially if you talk about people with SUD, because there's no communication back to the PCP, right? Now, if you have figured a way out in getting all this coordinated, please raise your hand, I'll come and talk to you. I'll kiss your feet, actually, because we found that for a solo practitioner is very, very difficult, right? So we participate with the Association of Community Affiliated Health Plan in 15 agencies across the nation looking at system realignment program. And in LA Care, we pick, again, the people with the SMI at 2 pilot sites. So what we've done is a little bit Managed Care 101. When we got the list of enrollment from the state, we don't necessarily know who's receiving mental health services up front. So therefore, we, if the patient has not chosen a PCP, we will automatically assign them to a PCP. Hopefully a PCP that provides services in the area that they live in. Now, you do know that we do have a lot of homeless patients in HealthNet as well as in LA Care. Patients that we don't know where they're at, or we don't exactly know where they'll be tomorrow. So what we found is that the primary care assignment usually missed this population, right? So what we want to find out is if we know a patient receiving services at this clinic, behavioral health clinic, right? And we trying to get a relationship with that behavioral health clinic with a primary care clinic, like a better word, it could be solo practitioner, and we ask them to arrange a relationship where either the PCP team go on site to the mental health side or in close proximity, however way they work it out. And we will reassign the member who's sitting at the behavioral health clinic that was assigned to a different PCP. And the goal is, well, currently, if you are a therapist in a behavioral health clinic and you treat 100 patients, presumably those 100 patients might be assigned to a dozen or more PCP in that community. And for those of you who are behavioral mental health clinician, tell me if you have time in your day to contact the PCP and talk to the PCP, or if the PCP even respond back to you to help. Oh, look at that, we got some head shaking. And we know that because it's impossible for a mental health provider to deal with 10 or 20 other PCP. So what we're trying to do is match and go the other way. But remember, we pick the county clinic. So for that neighborhood, you know people with SMI go to that specific county clinic, right? So what we want to do is match primary care physician with that county behavioral health clinic, so that the clinician only have to deal with one PCP setting and have access to that PCP setting and have a real conversation in real time when they deal with this mutual patient panel. That's what we're trying to do, because we couldn't use one funding and give to the other, because remember I told you the funding are still in silo. So what are we attempting to do is to realign those funding to ensure that we not only match the right patient with the right PCP setting, but also match the right PCP setting with the right mental health setting.